Los invitamos a todos, por favor, poder ocupar nuestros asientos para continuar.
We invite all the members to please have a seat so we can continue with today's sequence and agenda.
Voy a presentar al comentario del... Bueno, muchas gracias. Entonces,
Well, thank you. Well, thank you very much. Let's continue with today's agenda and focus on the order. Today is an honor for me to introduce Anel Arellano Tejeda, our doctor. She's going to continue with today's Congress, the first general campaign of breast cancer detection and nationwide effort to achieve best institutional clinical practices in Mexico. Dr. Anel Arellano is an expert in her field in imaging, diagnostic capacities, and therapeutical systems in Mexico. She's a radiologist of breast cancer and treatments and intervention. She's working for ISSSTE. She's a doctor certified in radiology by the National Collegial Body Association of Radiologists. She's responsible for the national program to detect breast cancer at ISSSTE. She is the leading scholar professor of postgrad studies in fields of different expertise.
Buenos días a todos. Me tocó ahorita después del
Good
receso,
morning,
pero-
everyone. I know it's my turn to take the floor after the break. I know that you're all coming back to the auditorium. What I'm going to focus on is our experiences, the compiled experiences when we decided to kick off the initial national program to detect breast cancer. I'm leading this effort in ISSSTE. I'm the oldest sister of 3 siblings. I have 2 younger brothers. In my family, no one's a doctor. My uncles, my parents have been professors. Now, when I decided to study medicine, I had no idea about which school to select, which one was the best school, where to go as an intern. I didn't know which were the best hospitals in the city and the apparatus to go and study postgrad studies and achieve my expertise or specialty. I didn't know much throughout my development as a professional, and I messed up at some point in my journey. But with humility today, I'll tell you that I want to continue growing today. I give you this next example as an example of reference because this triggered the national campaign to detect breast cancer. ISSSTE celebrates 60 years, and the first institute that's even older than ISSSTE is the National Mexican Institute on Social Security. That IMSS celebrates 80 years. When the doctor, my higher up, invited me to generate this program, she called me to start this reconstruction campaign, this national program. But first, we had to deliver the initial results. My higher up, my mentor taught me to build a program, and that model can be replicated and used in different scales. That's how I've been focusing on developing small-scale projects, and then we replicate the scale in other departments and units of the healthcare apparatus. That's how we triggered this national campaign. I turned to analyze other national apparatus healthcare institutions like IMSS, and I didn't have all the tools. I didn't know how to start the process. I didn't have the nuts and bolts and the know-how, but I'm an expert in breast cancer detections. We're radiologists. We're you're not working in the field of reconstruction of breast. When I had to analyze the management of the apparatus, so we all had material resources, needles, hook wires, tisular scalpels, and other tools. I needed those tools to remove a breast. I needed the models of the tools, of the material resources to open government procurement and bid so we could obtain the best material resources. I didn't know about tools to expand. I didn't know about heights and levels and thresholds. I was not knowledgeable in all the fields. I had been appointed as a lead in a department. My higher ups told me I didn't have to be an expert in all the fields, but with humility, you have to understand your weaknesses and strengths and communicate with other colleagues so you can really narrow the gaps. And I asked my colleagues for help in their field of expertise because without their aid, I would not have been able to achieve what I need to achieve. So we started our project. Pardon 1 second.
Ahora sí. Como el día de ayer, decidí siempre
Just like yesterday, I decided to start my conversation with you, sharing the pictures of my patients, because that's who we're working for Mino, for Amparo, for Mauri, for other patients who have been in this journey throughout the process. These photographs of our patients can let you see that they're smiling. We have a micropigmented the nipple of one of our patients. It's part of a step of the patient's journey, as I told you yesterday, with a micropigmentation campaign and their pigmentation of breasts, so that our patients leave the unit happy. There's so much to tackle, so much to improve. In this project to reconstruct breasts of our patients, we decided to start the program in the hospital called Rubén Reyero, and this was a major scope of the campaign of the reconstruction of the glands. We had, given services to 52 patients. I went to other state entities of this republic in which they wanted to implement the same government program. But the patients had to buy their own material. The healthcare institutes had to supply the material resources, not the patients. In another exercise, we worked with other bodies or foundations or associations who donated the implants for the patient, their prostheses, and they came with the prostheses for the reconstruction of their breast. All the prostheses were in small scale, and I needed a representative sample of numbers without committing many mistakes. So I didn't want to fall into conflict with the administration, because if we want to implement a program, you have to explain this to the collegiate body of examiners, practitioners, experts, other disciplines, not only administrators, but our government program was a campaign that needed to impact the patient's mental health, stabilize their body, recover their trust. And how do you explain other stakeholders involved the budget that you need for the program? I had to formulate a spreadsheet, technical specifications and scope of the project, feasibility at a local scale. It wasn't written how the healthcare apparatus had to go through procurement of so many material assets that are so peculiar, specific for certain types of characteristics of the anthropology or the anthropometric characteristics of a patient. So after kicking off my explanation of what we had done with this program, I'll continue explaining what we've done. If you think about taking the project to medical staff, operational staff, admin procedures, administration of things, it increased times two the difficulty of the implementation of the program and the scale. I always had higher ups, Vanessa and Ramiro. They guided me to achieve the objective to approach the right people so they could help me generate a clear document, a clear instrument. We drafted all of these official instruments for the bid and procurement to take place. And I opened the project to them. Nobody taught me how to do things. If an institution needs the program, we have it for you. We've laid the initial bricks. We've committed mistakes. That's true. But if we're in the decision-making process to implement such a scale of project, if there's no written standardized procedure that's been previously created, you're always going to fall into mistakes. In this program, nothing was perfect. Not everything gave us beautiful results, but I can tell you where I committed mistakes. So when you run into your own program, then you don't commit the same mistakes. Lessons learned. I can tell you the cases of specific patients, and I can call in the surgeons in this nation that practice in the operation units to
Esta leyenda me gusta mucho y la vi en
You
redes
know,
sociales en un
this
estudiante de
question is
izquierda
something, and
mujer
this
que habla
video is
sobre
something that I liked a
esta
lot.
noción
And a
de
chef
depresión hace algunos
participated
años.
with us, and
Entonces,
many
él iba
people that
mucho a los lugares
participated in
en todo
this
el mundo,
clip
desde los restaurantes más caros hasta
died
los
many
lugares
years
más
ago. It
humildes,
was
a
Anthony
comer las
Bourdain. He
delicias
was
gastronómicas y además
always
no
visiting
pagar accesible
different countries,
en
enjoying different foods that are heritage in
en
different
todos los lugares
nations.
del mundo.
So
Decía,
I
¿cómo
love
puedes
this
pasar el tiempo con las personas sin
data, and the
identificarte
question
con
is,
sus
how can you
pesares?
spend time without identifying yourself with
¿Cómo
with
puede
what
el hecho de ver su dolor
hinders
no
them or
cambiar tus
weighs on them?
principios
How can
fundamentales?
not
Y lo quise
seeing
poner
their pain
porque
change
a
your
pesar de que este
fundamentals or your
proceso no está
principles? And I
considerado
wanted to
como parte
see
de la
that, you know,
rehabilitación
this
integral
program
y
is
no
not
está
part of the
considerado como
integrating
parte de la
recovery
rehabilitación integral
process
de
or
una
phase
paciente
of the
sobreviviente de
patient.
cáncer de
You know,
mama,
if you're a
entonces
woman
existe
survives
y dice,
cancer,
no lo
breast
necesitan.
cancer, how do we
Personalmente lo he
reinsert or
vivido con
integrate?
gente muy
Or, I
cercana a
mean,
mí,
we've lived this
teniendo
with
la
people who are
atención
very
desde un
close to
sistema de
us.
salud como el
Even
mío,
if
yo
they're
hace un par de años
beneficiaries in the
todavía fue
healthcare
el IMSS
apparatus, I'll tell you that
y así,
EAMS,
te operamos,
this
claro que sí, pero ¿cómo
you know, at
puedes?
EAMS, our patients
Y
had
esta
to
persona
be,
estaba pensando, bueno, ¿y ahora cómo,
well,
con
they had to
qué tanda
be
voy a organizar
subjects of
para que
surgery, and then
puedan
they
decir
had
que
to
tenía
get their
cáncer para comprarme
prostheses or
implantes
their
y que aparte iba
glands
a ser
to
drenado
then
y
get a
aparte del otro
surgery
lado tengo el
practiced
seno
on them, and
materno
they
y
had to
entonces
buy
cómo voy a
it
pagar
themselves. And
coletas
then
y entonces
the
cómo
women involved thought, okay, one side of my
proceso de
chest is bigger
rehabilitación
than
porque la
the other. How
rehabilitación
am I going
cuesta
to
porque
be
mi respiratorio
balanced? And
demanda
then
todas esas cosas que
rehabilitation
ya hemos visto a lo
to
largo de
renew
este documento
ourselves.
que se
And these are things
descompone
that we've
que nos
discussed
impide darle
throughout the
la atención
Congress,
integral a las
so
pacientes.
that there's some things that hinder or impede
Y
us
nuevamente,
from giving our
me gusta
patients that
cuando todos mis dramas
total
empatan o
or
coincidan o
global
tienen que ver
services. We
con los
tie all
dramas que
the
han presentado
faces
las
with the
maestras desde
charts
el día
that
de
have
ayer.
been submitted
Todo el
in this
procedimiento
conference since
escalonado,
yesterday. All
todas
of
las
this
fases por las que atraviesa una
total
paciente
phases, all the
empatan en los
journey that a
mismos
patient
lugares,
has to go
en donde
through,
nos tenemos
tie
que
up,
enfocar.
we're
Yo creo que
bridged
ya nos
in all
quedó
the
más que
steps.
claro porque
So we
el
need
día de
to
ayer les
focus with
platicando
clarity
que
on these
algunas de las
programs. And
pacientes,
we've
ellas ya
discussed
entendieron,
these
para
matters
mí la
since
diferencia
yesterday
entre
with
revisar y
of what's
diagnosticar
happening
muy
with our
poco.
patients.
O sea,
What's the
ya con
difference
eso
with the timely
parecería ser
detection and
absurdo, pero la
screening? It might
democratización de la
sound
información
absurd, but
y que ellas nos
the
entiendan, es súper
democratization of the
importante. Ellas
information,
pueden,
how you
ellas, las
communicate, is
pacientes, son
very
las primeras
important. We have to
referentes
communicate
de
with our
comunicación con
patients
otros
because we
pacientes.
are the
Cuando
first
están
channels of
sentadas
communications, and
esperando
they
por su
become the first
mastografía,
channels
¿con quién creen
of
que platican?
communication with other
Entre
patients.
ellas.
Patients
Cuando están
communicate
esperando su
amongst
consulta con
themselves when
oncología,
they're waiting
¿con
for
quién
a
creen que platican?
mastography,
Mientras
when they're
duermen,
at the
así con
oncology
quién creen que
ward. Who
platican.
do you think that
Siempre
they
se informan
communicate
con la que
with?
va
With
un
other
poquito más
patients.
adelante,
They
no es su
always
hermana
communicate
mayor
with
del
a neighbor
procedimiento.
patient, their
Ellas se
older
van
sisters who
informando,
are
por
going to
eso esta
undergo the
información que
procedure.
les llegue a
They
ellas,
obtain
a
that
mí
second
y que la
hand
comprendan, porque
information,
siempre
and
decimos, no,
they need
nuestros
to be
nervios son muy
capable of
relevantes, son muy
explaining and
importantes. Los
understanding
pacientes
it.
nos
You know,
entienden
our
y estamos
patients really
logrando este
understand us,
proceso
and we're
de entendimiento
achieving
por
better
primera vez que ya son
communication through
parte
this
integral de
Congress. We
toda la
need to
atención.
understand that our
En la
patients
segunda,
are
en la
a
segunda
part of
sesión ya
what's the
estaba
total
Raquel,
integration of the
Raquel,
services offered here.
la
Raquel,
doctora que presentó la
Dr.
aplicación,
Raquel, who discussed the
Vicky, es
developed app
patóloga,
of
pero encuentran
Vicky
todo
app
este
is a
trayecto tan, tan,
pathologist.
tan, tan
And
específico,
our
información de
professor with the
muchísimas
app
ciudades más a
thoroughly
nosotros
explained
pacientes,
how
ya
we can
sea a través de un máster
use these
en el
apps to
extranjero o de
contact our
dermatología,
patients
porque la
better.
mastología
She's
es un
having a
complejo,
master's in
es un
mastology
concepto
abroad. This
integral muy
mastology is a
complicado que no
very
es fácil de
complex
sobrellevar.
subject, a
Ella me
discipline
habla
that's not
mucho de ese
easy
tema,
to
se acerca mucho
understand.
de
Our
todos los expertos
professor,
con
the
los que
development
platico
of the
respecto
Vicky
de esta
app,
materia, porque
contacts
se
me with
acercan
other
conmigo y que
experts
yo
from
pueda
other
escuchar para
disciplines that
conocer sus
approach me,
inquietudes
that I
o
listen to, so
imagínense
I
que
can
utilizan el
understand their
resultado
problems. The
profesional. ¿Por qué?
histochemistry
Porque la
capacity in the
industria, la
regional
docencia,
hospitals is null because
y
the
la manera de
industry
distribución, pero
will
nosotros tenemos que
sometimes
tener
offer
nuestros
certain
paneles de
services to
interdisciplinaria,
our
no solo
government
para cáncer nada
apparatus.
más,
We need
sino
to
para
have our
todos. Pero bueno,
histochemistry
otro área de oportunidad
departments
donde
for
estamos
cancer
trabajando y
detection
generando
and others.
proyectos
That's why we're
correspondientes
working
con
on all the
nuestros líderes
branches of
dentro
the
del mismo.
program. So we're all
Después llegar a la
integrating and
interdisciplinaridad.
analyzing the global
En este
stance.
pedazo
I
tenemos
mean,
un
we have to
cáncer.
work
Es uno
timely.
de los escalones. Ahí
In this
deberíamos de llegar.
program, there's
Nosotros
gaps.
todavía no
There's
estamos en
steps
una
in the
posición
journey.
donde yo
We
les
have
pueda
not
decir,
achieved
tenemos este
meeting
proyecto
all
o
the
tenemos
gaps. I
esta
can just tell
solución.
you that the
No,
project's
todavía no estamos
complete
en
and
ese
that we
lado.
have a full,
Nos
complete
saltamos
solution.
y
That's
saltamos
not
algo un
where
poco
we're
más avanzado.
standing.
En los
Let
centros de
me
atención
skip to another
integral de
step of
mujer,
the
teniendo
process
que
and
abrir dos
trying to
unidades de
integrate
estos
women and
espacios 2
reconstruct them
años,
after breast
en
cancer. It has been a journey. We've analyzed what's happened in the past 2 years. We wanted to have a department to detect cancer timely, and we had to develop a clinic of examination to detect cancer, and we needed to have another infrastructure to reconstruct and rehabilitate our patients when they suffer myectomy, and to rebuild or reconstruct our the pelvis of our patients. So we need more material resources, and it's required. Those material resources haven't been considered in the budget allocated for the expenditure. If a program doesn't shed results, numbers, solid numbers, then it's not registered before the SMEFO, the medical apparatus of budgeting and financing the system and apparatus. If it's not in the budget, then it's not If it's not been submitted before, then it's not paid for it. So there's nuts and bolts in the project, but we have to make sure that the government project works at a local scale with a budget of government. So if we lay the bricks and create the roads to simultaneously treat our patients in other areas, in other steps, we can achieve the objectives if there's budget allocated for one project or program or another. So the last step, so it was fundamental for us to think about the program for a procedure or a program to for it to achieve success, you need to have harmony in all the elements. You kick off the government program, there's a leader of the project or program lead, and my higher-ups need to agree and accept the submitted program, and they need to communicate to their higher-ups and higher levels of dialogue so that we receive the budget allocated to buy material resources. So the Revenue Ministry has to allocate budget for this government program to be material, to submit final results, draft the executive report, made it official in the gazettes, and when it's necessary, we have to make it feasible to be in the proper conditions with the whole program and the general scope, procedurally speaking, to go through the other procurement stages. I mean, with EAMS, we had to draft this into a standard, the national norm or the standards, the Mexican norms. EAMS have drafted the norms of this program, and it's part of the legislature. We still hold this as a program in the General Nations campaign. I discussed this with other discipline surgeons. We share best practices and debates, the best ideas, lessons learned. I called other disciplines with the expert panel in that council to discuss what needed to be bought. I asked that table to help me draft the program because we shared results. We keep a record and a log of our patients. We've obtained statistic information about their level of satisfaction with the program. We've achieved a part of the goal. It's part of the national scale program. That's how we work at ISSSTE. It's not just proactive, it's reactive. If the program was positive, replicated. We didn't have previous planning for the implementation of the program prior to this 6-year administration. We had to continue working, and political will was necessary, and the stakeholders' will was necessary. So it all adds up. So it gives us shining light. We had kicked off the campaign of micropigmentation of women's nipples with Alejandra. Alejandra started working with us in this program. Many involved want to see the beautiful side of the pigmentation in the program, but it's complicated. There's also reconstructive phases and rehabilitation phases, and we were open to room for debate in this roundtables of discussion. That's why we've all been summoned to be part of this international Congress. This Congress is not being held in our apparatus, but we've invited so many patients, so many people, or so many professionals in our disciplines, and we're all contributing to build this system stronger. Now, how can we replicate this program? With humility. With humility, I can approach an expert that has more knowledge than me. I can tell the expert to narrow the gaps that I have or the loops that I have. I must ask other experts for help. If we're all working in the same hospital, in the same floor, I can go to the other floor and check the expert report of a radiologist. Why would it just analyze the patient's report or documents or file through a low-resolution screen? If we're already in radiology, if we're all trying to serve the same patient, we have to obtain or reach the mission in with multiple disciplines involved. We're trying to rebuild our women's breast timely. And reality, is the opposite. We have to open and give the patients the opportunity to rehabilitate themselves. And I've asked my patients and interviewed them about our campaign. I tell them, what do you think about the recovery of the glands? And right now they're in the tisular stages. The tissue is hurt, and it's not beautiful when they've submitted themselves to surgery. But we've gave the patients the opportunity to rebuild their chests. When women have the option to rebuild their chest in the system, they change their minds because the decision is in them. They can either accept to be rebuilt and accept the procedure or not. We give them the opportunity to select, and that changes things. We're not the first country to do this. As I've told you, I look for other programs or pilot programs that were executed in Mexico and Latin America too, because when I started researching regarding the programs and the scalability of the national program, it had to be massive and it had to be implemented in all the state entities of this country. I started analyzing the stats, the numbers of Mexico and other economies, and we had the data of the institutions, and we combined the data data with sponsorships, budget allocation, and other stakeholders involved that gave money through some associations, and we went through procurement, and EAMS received donations, and there's things that financially we could trace, or there's tracking. We needed to generate the instruments that were the technical specification sheets to be specific. This is data from Panama. In Panama in 2015, they submitted a government program to rebuild women's chest or glands, and they went through procurements and bids. In Colombia in 2022, they amended the law called with Alejandra Ceballos, and it was avoiding the barriers that hinder the reconstruction of our people. In Peru in 2023, they kicked off a government program to reconstruct breasts in their females. In Bolivia, at La Paz, we know that they celebrate the International Day or the Bolivian Day for breast reconstruction. Chile issued a decree to have the thresholds to protect our women, to rebuild our patients' breasts immediately or with deferment payments. In 2023, I went through the thorough global research, or these countries' research, and an observatory had a log of the registry of patients waiting surgery when they finished the oncological treatments. So there's many campaigns that didn't start immediately. Like in Mexico, our patients that received their final oncological treatment, after that treatment, we can tie and bridge this phase of the project with the other programs modules. So we didn't have to mandatorily interact with oncology and plastic surgery. Some of the plastic surgeons in this country have been capable of bridging with other departments. There's a lot to work in. Some professionals don't want to bridge and communicate with other disciplines or other professionals. So the development of many involved in these programs, have to tackle timeframes. Those who are just recently receiving their degrees are highly conservative. Usually they execute the conservative mastography, but there's other surgeons that are experts in oncology, and they have their reasons to decide what surgery to practice based on what's institutional. There's patients that could receive chemotherapy, radiotherapy, and patients can't risk suffering the growth of the tumor once again, so they'll go through mastectomy. And some doctors are just working with this conventional treatment. We haven't convinced them of the fact that we have the full program and steps to follow, so the treatment is leading us to the reconstruction of the breasts of our patients. So we have departments to integrate other professions to rebuild our women's chest. And in Argentina, it's part of the General Act. They've drafted it in the law, the 20 or 72 law, to surgically reconstruct the women's or the patient's breast. Fortunately, when IMSS celebrated 80 years, it's like enforced, it's law, it's enforceable. And we at ISSSTE celebrated 60 years. So in our ISSSTE authorities, we have all the assets necessary with the right elements of the program to include in the services, all the services and the material resources to go through procurement to offer that reconstruction as part of the campaigns. We still have enough assets to operate 750 patients that are waiting, but we need more. So we needed to see the results in the first exercise of the program. We need to submit the reports to all of you professionals. The surgeons sometimes are not as clearly on board as part of this government campaign or program. They have to be passionate about rebuilding our patients' lives. So they need to know that our patients need this and deserve this. So we need to take this program to local actions and communicate this program, because we need to cut back on surgical times, and we need to have priorities in our patients for telecommunication with our patients, and we need to communicate with other state hospitals that need to operate their patients, but they don't have enough surgeons. Now we can also think about the travel needs or economic needs for the patients to travel and the surgeons to travel.
It is always said by my bosses, we will find a way, but at least it is a sentence that wouldn't make a lot of sense to me, because many things need to be submitted to attain it. But finally, it has worked so far. And well, I hope that how this campaign can become a program, and I'm certain that we will achieve that. That is a matter of continue working and give results. For the breast reconstruction public policies specific in Mexico, in 2019, the Congress approved the third Friday of October as the National Day of Breast Reconstruction, and it was decreed in the Daily Gazette Gazette of the Federation. The publication was in January 2020. In April 2019, the then Senator Miguel Ángel Mancera presented an initiative to consider the breast reconstruction as part of the basic services of health. It was approved in the Senate and turned to the upper chamber in 2020. As you'll see, from 2019 to now, small actions have included institutionally and locally and up to the federal level, as in the Congress. We have in the 10th Consensus of Colima, published in 2023, it is acknowledged that reconstruction is an integral part that causes impact during the life and the quality of life of patients, irrespectively of their oncological status. This means that not because of that they have a poor prognosis, they can be interdicted to breast reconstruction. They may have the conditions that they feel or to approach them to before they felt before cancer. And although her clinical prognosis is not the most favorable one. And in absence of contraindications, the agreement tells that all patients need to be patient to immediate reconstruction to minimize the negative physical and psychological effects of mastectomy. The word mast is also complicated to us because something is the mass and other is their actual features of the health system that prevents us to do an immediate reconstruction to all of them.
Para esto, pues entonces empezaron con los.
They began with direct efforts in Mexico City, and of the work I found, of the pieces of work I found given by these campaigns from DIF and public beneficence in Jalisco, Sinaloa, Durango, in Mexico. It is offered as the National Institute of Cancerology and the General Hospital of Mexico. They have also registered donations from organizations from civil society, private initiative, and medical associations. And well, we in 2023, we made possible the entry of codes in the catalog and a total purchase approximately in the calculation that we present of 745. The calculation of the purchase would give 943 patients. However, we got a little bit less of input, and this was not institutional. It was availability of suppliers of the amount of product that they could offer in that moment. And then we had to cut it there. And for April 2024, after that we began with this campaign, the Technical Council of IMSS approved to extend the coverage through benefit holders who receive their mastectomy derived from breast cancer. So national efforts have been done. We were not the only ones, nor the first ones to start with all these efforts. First, it was the private initiative, and they were smaller campaigns. The difference with our campaign is the massivity that we wanted to approach all the states in the Republic because of the availability of having regional and general hospitals in the whole Republic. What we did first, and I was telling you at the beginning, we assessed the needs. And to know the needs, we need to be an expert in the area. So we didn't have any surgeon expert in the area. So invited all the regional hospitals to send their surgeons, plastic surgeons, so that in an agreement of experts to tell us in the best scenarios, if this was Christmas, what would you like to buy to have a breast reconstruction campaign, going from the top to what is actually needed. If you want to buy a big car, but if you can only buy a smaller vehicle, well, but we can do that with it. At that moment, we didn't have a budget established because the purchase process is not, okay, you have 10 million pesos to spend in that campaign. No, well, then I see how I can distribute it and what I can buy with it. No, it's the other way around. First, you need to define the input, then you find how much it costs, and then a market study, and then you need to get a tentative budget, and then do the final purchase. Given that the processes are complicated and the managing processes we had to follow had not a mental logics, the exercise was to first do it with the plastic surgeons that we called, as always, and I will always thank that. It was in my hospital, my school, the first ones to raise their hands and tell me, Dr. Rodriguez and Adolfo Lopez Mateos Hospital. Let us go to your meeting and we will go to the medical directorate. We want to buy this and that. Dr. Milla in Zaragoza Hospital currently is empty, and Zaragoza Hospital has no plastic surgery residents and is the person who has operated more patients in the whole Mexican Republic. And I tell you like this, gender has to do with this campaign because the two doctors who decided to work with us, the two female doctors are women, and that has an influence a lot in knowing that that empathy exists and that wanting to work with other women has to do directly with the feelings, emotions, and the perceptions of a lady with the patients. I don't mean that male plastic surgeons do not have that. I see many of them who are students from Dr. Rodriguez and who were fortunate that in addition to have a professor that wanted to support the campaign, they are receiving also a training during their process of learning and residence to have specialized treatment in breast reconstruction. At least in time when I was doing my residence, totally different of imaging, and I met the plastic surgeons that had to rotate in other institutions to be skillful on the matter because we didn't have that in the health system. So assessment of needs was made, design of services, and then we went to the allocation of resources. And finally, we're monitoring and assessing the procedure. Everything is perfectible in every part. We had small errors, and I will mention that in brief. And, in the sense that our procedure was always guided by people who knew more than us, but we need to state what are the things where we need to do fine-tuning, and those things where we, if in a second exercise, it won't happen again. And for this, and given that this Congress has all this spirit of integration and collaborative work, and I tell you from the example that they are only used to treat with more specialists, radiologists, specialized in breast, and in my small world, I didn't have to integrate with administrative staff. For me, it was I only want this, where you get it from, or what is the bidding, or what is comprehended. Many things that I am only understanding how they work now, and that is working with the administrative role. The organization of this Congress, I was telling you yesterday that it was made with an area that normally the medical division has nothing to do, and we made it possible with perfectible things, but it is like that. If I don't know who to hang around to make this happen, and finally, operational doctors, because definitely taking medical inputs has to go with a doctor. If you don't know what it is used for or the pertinent care that input needs to have, then you will not have success. Those small 4 steps seem to summarize everything, but to get them, we delay. Well, in all the administrative processes that I have known in ISSSTE, the fact that this campaign was accepted in a year was not necessarily so complicated. This scheme and this continuation that you see, it was developed to explain in an administrative delivery, because it was managed like that, how we did it and how we bought it. Because this campaign and this input can be used to bad aesthetic misinterpretation. So we didn't want to get, why buying these inputs? And they were asking, how do we know that they will not finish in the wife of any subdelegate or director? Or how do you know that that input will be effectively placed to breast cancer survival patient if you don't have records for that? So it was a big reason that yesterday it was said that there are some people who are very naive or who do not think wrong from the administrative part, that this could be used to deviate resources from the institution or to remove its positive nature of the procedure, because then it will become okay, ISSSTE is giving implants to everybody while not taking care. So it can be perceived many things. My bosses would tell me, be careful here and there. These political forms are not like this. So my training as a doctor, I didn't learn that until now. Finally, we generated a flow diagram for a procedure of 1 year. We started with a nominal census my first mistake, and you will say you started bad. No, in our original census was numerical. After the forecast, according to the amount of patients we had, and in the high-risk age stage, and according to calculation of incidence of breast cancer, and then an extra calculation of how many breast cancer survivable patients are candidate to memory reconstruction. And the last big mistake, how many of those patients actually want the procedure? Because we assume that all of them that survive breast cancer, they want the procedure. Because in my mind, from my view and the view of the original group, that all the patients would want it. And it is not like that. Not all of them want it. So it is a calculation. We didn't consider that variable. So, well, that was the
campaña, un censo exclusivamente nominal.
what I suggest for the next campaign, nominal census. Zacatecas has exactly 200 survivors of breast cancer in your census, and you need to generate from your oncological records, and from those patients you currently have out of danger, how many of them who are candidate to our reconstructive procedure free of disease. We only have 25. From them, you need to tell me who wants the procedure or not. You will send me 10 of them, and those patients need to come in a nominal census that involves all the variables that the patient needs: the name, the age, the height, the weight of the contralateral breast, if they have it, and to standardize the size and volume of the expander and the implant, and if it will be a bilateral procedure, or if we need skin substitutes, or with only an autologous flap, and a wall procedure only and specifically addressed to that patient, so that our purchase is addressed to specific inputs that those patients will need from that nominal list and not numerical list. Next is the identification of needs of inputs. Second mistake we had when the acquisition was made of implants, expanders, consumable sets, and substitutes of skin. They were entered in an independent code, all expanders in a code, all implants under a code. What was the error? And we paid costly, the doctor who ran the campaign and me, by not having every volume of expander, 220 of CZ, a code. All expanders from all the volumes arrive under the same code, and everything was stayed under the same code in a warehouse, and we had to have an extra process of knowing what lot every piece belonged to then in that census divide it per volumes and heights. And then being in the possibility that when Dr. Lises in Sinaloa would ask me an implant of 300 cc, an expander of 270 with a certain height, I had to go and check my record, which was a big Excel spreadsheet of how many pieces we had of those volumes to do the specific shipment of the piece. So it became very complicated. What it should have been, every volume of every implant and expander should have had a specific code. And then we made the division of inputs and a technical file that is specified exactly, not for other doctors, but for administrative staff, why that purchase was important, why statistics had to include the opinion of the patient, and what could come from public campaign of this campaign. Fortunately, it was good, and public opinion will always be right with good things. But anyhow, we had to consider all variables in a technical file, not only of the why that input, but what would happen after the purchase is made. Once the technical file was ready, we get bidding with administrative parts, and then from Compranet and other tools directly addressed to the suppliers. With the medical part has nothing to do with the purchases. That's something important to separate, because I didn't know that the administrative part has to do all the pertinent procedure to get that purchase. We need to be very specific as doctors on what you need to buy, because once that process gets the administrative part, you don't see it anymore. And that is good, because then the industry and the medical part are separated, and we eliminate the possibility that there are
del área médica para con respecto
any
de
person in the medical area with regards to the industry. And that is something that was of our concern, because that is a complex input, as I commented before. So we couldn't submit it to misinterpretations and to deviate the campaign by thinking that, oh, well, okay, that Anel will get 80 million. No, since I have been in this position, I have been less poorer, because I work more in the institution. I work long hours, not in the private practice. So, well, removing that part of interest, you move it because of social interest, because you want to actually make that the patients you know and those you don't know have the option to decide if they want to proceed or not. And finally, the acquisition was generated and we made it.
Esta fue parte del cálculo que
Well,
les
this was
platicaba.
part of the calculation that I told you before.
Antes. Una antes, por favor. Esa. ¿Ok? Entonces, yo les platicaba el día de ayer que soy muy afortunada en trabajar en una institución que tiene tan
yesterday I
sectorizada.
was telling you that I'm so fortunate to work in an institution with a sectorized population, 130 Mexican inhabitants. I attend 13.5 benefit holders. From them,
30 y
the
69 años,
patients in age groups between 30 and 69 years of age, because in this campaign we have included patients not in the high risk age stage, which is 40 to 69 years. We made a calculation with a number of patients existing between 30 and 69 years of age. From there, the result, which is 6.7 million benefit holders in Mexico who were feasible to receive the treatment. After that, we made a calculation of the incidence of cancer globally from the national and international statistics, and the result was approximately 149,000 patients. In turn, we made a calculation of breast cancer incidence, and we got 50,000 patients in that incidence. Then we made a calculation of breast cancer patients who were receiving unilateral bilateral mastectomy, and the universe became smaller until we reached 26,000 patients. And finally, we had an approximate census of 7,913 patients who could be candidate to mammal reconstruction, and we established after many calculations and after many numerical census that match with our calculations, the numerical sense would give us from 20 to 100 patients, and the approximate calculation of purchase for the finalization of all patients after all these derivations and having the smaller universe would give us 765 patients. So it was finally the amount of inputs that we decided to buy. And in addition, because they were those that matched most in the number that the industry had available to sell, because the bidding was open, and few companies told us that they can sell that amount of implants, and they postulated. I can tell you the amount of surgical sets. It was not that easy.
La que sigue, por favor. La anterior.
Next, please. The preceding one.
Ah, ok. Bueno, ya después de eso, lo que debíamos de haber hecho siempre también desde un inicio.
After that, we had to be done since the beginning. We called the plastic surgeons, and not all of them addressed the call. Some of them were on holiday. Some of them, they declined our invitation. Some others only wanted to give us a phone call to say, oh, no, we don't do that. Oh, no, we don't have the time. We are saturated in our agenda. I always say that I have to work with 32 states and 35 delegations in the state. They don't care. I have 31 others who work with me. If a hospital doesn't respond to the call, I have other 14 team with whom to work. So it is like that. When we are having something like this and we want immediate results specifically, as it is my case, the results need to be now because my heads want results now. And we need to help patients now because we have a time chain where, and I cannot leave things pending, the thing that I have started. So if you don't want to work, okay, we go to the next. And we went to the original census of plastic surgeons in the Republic who wanted to support us in the campaign. And we focus our efforts with them, not that other states didn't have patients to operate. All of them send numerical census of approximate numbers of patients who wanted to be operated, but not all of them had the surgical equipment needed to run the campaign. Finally, we grouped 29 plastic surgeons enrolled for the strategy and 16 surgical units, including National Medical Center, 20 de noviembre, but something that made me more happy, general hospitals. You don't need to be a regional hospital to have access to a service or give a service of high specialty to a patient who needs it. If there is a waiting room and a plastic surgeon, the procedures can be perfectly done in a hospital, not necessarily in a regional hospital. And like that, we launched our campaign on January the 6th, 2024, this year, after 1 year of administrative purchases and heavy and demanding logistic processes. We ran our campaign in January 2024, and nobody answered. What happened? We sent an official letter to all heads and the delegates and all directors, but official letters is a paper. If the instruction is not given to operational doctors, it will never happen. So March came and we had not operated any patient. So the bosses wanted results. So I started to ask the operational plastic surgeons one by one, haven't you operated? We have all inputs. The only thing you have to do is to ask them. You don't have to ask them anybody. The scenario and the physical space where everything is located is available. No, we didn't know that your campaign had started. Okay, so we need to roll out the information, that administrative information from the medical directorate reach the operational essential characters who need to be in contact with us. In the end, after those months, they started to operate patients, and their own complications began to appear from one of the two doctors that presented results, especially the absence of operating rooms and surgical timing. I think that was the major complication of all, to start calling the patients, convincing them. There were states saying, no, there's no breast cancer here. 4 of them would send the nominal census and they would say, no, we have called all of this and they don't want. How did you off the campaign? My boss called them, why don't you want to be operated? Is this offering this? No, I was not explained. They didn't call me. They didn't tell me this. Would you want to be operated? Yes or no? So like this, where is the personal work? And then in the observation of the application of Raquel, they was criticized on what is the closeness between medical and patient. Don't tell me that it doesn't exist and it is perfectly the same, because that is not reality. So, well, that is what happened with some of the states, but I insist, I don't fight with them and I continue to work with those that are available. So far, we had 292 operated patients from March 2024 to August 2024. So for those few months working as such, and with all the complications implicated and the number of plastic surgeons we have, our results, in my view, are very attractive, because we have the operation of all of this. And sometimes I wanted it to be faster, but when I see the final numbers of other campaigns that have longer than mine, then I think we can continue to make it. We will let it establish. We'll finish the inputs. And then when a second acquisition comes, I will continue to ask this input, because I needed to give attention to patients who next year will receive the treatment, or to convince doing a strategy with the correct organisms, and to draw more patients from other places. And there's patients who receive attention in private. For certainly, a certain part of our population has that possibility to draw them to us with private organisms to make all patients participate in this. In this graph, I wanted to show off the results of our plastic surgeons. I thank them a lot because from zero or nothing, well, this is only a patient at least. In Lopez Mateos with Dr. Rodriguez and their 19 residents, of course, we would have some results, of course. And Dr. Milla, who I admired the most, how being by herself and always fighting with the oppressing patriarch group. We serve their patients, Camila de la Vega. Another important factor, plastic surgeons recently aggressed students in these hospitals. They are also given results in terms of numbers. I don't like to think in patients about numbers, but to give administrative figures, we need to convert them into numbers. The procedure that we have been made is the collocation of implants and skin substitution. See, that's an expected result, and we have that input, which is totally valuable because it is not available anywhere else, and it is in the same level of any surgical procedure made or included in major medical expenses. We have that input for patients who unfortunately have lost a lot of tissue, 3 different types of skin substitutes for support and recovery, to aligning to facilitate the work and task of plastic surgeons, to give them more procedures in their hands is the election. And but I like to know or to think in the moment that they need that we have it, and it is not only inputs needed for a mammal reconstruction, but for burn people, closure of neural tube defects, and there are inputs that are used for many other things. And again, figures and seeing how Dr. Rodriguez, who have operated more patients in the whole Mexican Republic. And to me, it is not surprised that they are 2 women, the people who are operating more patients in the whole country. And finally, our strategy in the current moment, I still don't have statistics of data of output of the satisfaction surveys that we will start to give to the patients, because all of them are in the processes of early recovery or expansion from implants. And if I ask a patient in early recovery because of this procedure, they will say that it is discomforting her and they are not so happy. So the campaign was bilateral. Many of the patients are being in recovery and they refer what they have learned immediately, in addition to the feeling something on their chest, is the recovery of balance. So things that we may not consider for the first time. And something else that I find since the beginning is our training personnel, our resident doctors are having access to get dexterity in these procedures without the need to rotate in other hospitals. We are offering them something else to this subgroup of doctors who are not employees or students, and that we exploit them in an aggressive way. And I say this because I was a resident too, and I was exploited. And we thank the collaborative work, and the Lopez Mateos Hospital has traveled to other general hospitals where there are no plastic surgeons to operate the patients. So we do not send them with more available luxury. The transportation and their lunch was very scarce, but even like that, they go happy to help in other places. So even collaborative practices are beneficial. And I will not elaborate more because I'm out of time, but results have finally been positive, and our learning continue to be part of the process. We got wrong in few things. To be the elder brothers in a procedure, we are not messing too much, and our younger brothers chose a better place to choose their internships, and they came to do their specialty studies in Mexico City, and they will continue to have much professional growth. So in some time, my errors, our errors as an institute and as an organizing process of this campaign will help to other hospitals. So when they run a campaign, they are wrong less. So we are the elder brother in all of this. Thank you very much.
Gracias a usted, doctora. Y en
Thank
este
you,
momento
doctor. And
entregamos
in this
su
moment, we
reconocimiento por
give
su
you a
destacada
diploma
participación
for
en este
your
primer Congreso
prominent
Internacional.
participation in this
Muchas
first
gracias,
International Congress. Thank you
doctora.
very much,
Bueno,
doctor.
pues continuando con el orden de nuestro
Well, we'll
programa.
continue with today's agenda, with today's sequence, and
Sí.
Muchas gracias, muy amable. Quiero hacer un comentario.
thank you very
Perdón que lo
much.
interrumpa,
A
y
comment
sobre
from
todo por el comentario que
I
hizo
am sorry for distracting you because of the comment that the previous colleague mentioned. Her observations were material. I mean, I'm 66. I was born in the past century. It's an honor for me to be part of ISSSTE as an institution with programs as the ones that were explained during the initial of the administration with Domingo Miranda. The programs are called I Take Care of My Health to detect chronic diseases. We need to understand all these parameters. You know, we just love that we're working in the primary services in the apparatus to keep control of the chronic diseases, and breast cancer is one of these conditions. I want to share this experience. Anel Arellano, the doctor, submitted this great project, this program. Just by looking at her and how she expressed the national program and what she had to do through it, through all of it. I'll tell you, I came from Iztapalapa, and in Iztapalapa, we offer services to the beneficiaries to almost 1 million people and over 1 million people. Those who are not beneficiaries, it's like there's so many people that we can really help. I went with a doctor to visit a unit, and she started telling them, okay, we need this. I don't have doctors. I don't have infrastructure. I don't have a nurse. I don't have this. I don't have material resources. And our doctor Arellano was just tapping at the desk. And I was thinking, and our doctor was just got up from the chair, and she thought about looking for doors to implement the program. This woman that you just saw at the podium really moved me. She moved my heart. She was sensitive enough to really, it's user patient centric. When we're using your mobile devices and you're there with a patient and with your doctor, what the patient wants is a solution for the problem, but they have 20, 30 minutes. And then when the patient goes back home, they forgot what to eat, what to do, what the instructions were. As I told you, I was born in the last century, and sometimes you've been given lunch, and when you go somewhere in the country, you might receive you might be given rattlesnake as food to try to survive cancer. So, I mean, think about the formal conservative ways to treat cancer. And I saw there's some things that we're not doing right. So we really have to be intelligent enough or sensitive enough as our higher ups, because as I told you, I was born during the last century, but Dr. Vizcarra, when I heard her, it was like, what do you need? She's always thinking, what should we do? What program to materialize? And when I went to Anel, she said, okay, we have the 13th, 14th unit to detect cancer timely. I'm here to serve you all, because in 15 days we can issue the diagnostic report. It used to take us a year or 2 years to issue the package of documents of the patients. Time is of essence for the patients. Please, when you in healthcare practice, think of the patients, think about them. They can be our family members. Give the proper services to treat our patients' cancer. That's in our hands. Thank you very much. And we thank you, Dr. Ramiro, and we thank Dr. Arreola and all the members involved. Thank you, ma'am, very much. Right now, we have time to present Alejandra Dayana Tierra Fría Peña. She will continue with a sequence of conferences called Micropigmentation of Nipple to reconstruct the aesthetics and emotional rehabilitation. Ms. Tierra Fría has received the national acknowledgement of the ISSSTE Award, the Pink ISSSTE Award in 2023. She is a technical practitioner of microblading. She's an independent practitioner. She has over 16 years of experience. She has a long professional development in the field of micropigmentation. She has received different national, international acknowledgments. She is a pioneer in the implementation of the micropigmentation of the nipple, using this in the medical field with us. Thank you very much, ma'am. It's an honor.
Hola, ¿cómo están? Buenas tardes.
Hello, everyone. How are you all doing?
Capacitación antes.
Can you help me change the slides, please? I don't know. This clicker's on. Thank you. Good afternoon. Thank you for inviting me. I thank the Inter-American Conference on Social Security for inviting me to this first international congress to fight breast cancer. It's an honor for me to take the podium, and I want to tell you what we've achieved with micropigment. Now, we're building or pigmenting smiles. We're rebuilding smiles, and we have to work and rebuild our women's smiles. They're tackling cancer, and it's been this part of the program has been well accepted by our patients.